Well, welcome everyone, and thank you so much for joining us for today's conversation. I'm Emily Hinsey, Chief Program Officer for Grantmakers in Aging. I want to thank our serious illness and end-of-life funders community for supporting today's meeting. The Serious Illness and End-of-Life Funders community provides a forum for funders with a shared commitment to improving the care of people with serious illness and end of life, as well as their families and their caregivers. This community was launched in 2015, and it now includes more than 30 funders. We would love to have you part of this community. It's an incredibly collaborative group of people who are passionate about this field. And if you're interested in joining us, let me know, and we would love to have you learn more about their work and to get involved. So our goals for today's conversation are first to understand the issue. Why is it critical to address disparities within serious illness and end-of-life care? And then secondly, what is the role of philanthropy? How can philanthropy drive meaningful change and reduce disparities? And then what are the solutions? So today we'll highlight 3 effective approaches to tackling these disparities. We will, toward the end of the time together, we will invite you to put any questions or comments within the chat. So we welcome you to do that throughout the hour as you think of things, but we will have some time at the end for any questions. We also invite you to use the chat to let us know you're on the call. So if everyone could add their name, your organization, and what brought you to this discussion in the chat. I'll pause for just a moment and allow everyone who's listening to do so. Just confirming, can attendees enter names in the chat? I'm not seeing anyone. Here we go. It was just paused on my end. Thank you. Thanks, Maggie. Anyone else on the line? Thanks, Amy. Glad to have you here. Thanks, Reagan. Thanks, LaRue. Jessica, welcome. All right, thank you, everyone. So I am now really pleased to introduce Lauren Poger, who is the founder and managing partner of Transforming Care Partners, as well as a strategic advisor to our serious illness funders community, who will provide some background on why it is so critical to address disparities in serious illness and end-of-life care, as well as moderate today's discussion. So Lauren, on to you.
Thank you, Emily, and thank you everyone for joining us today. So I just, before we introduce our speakers, I just want to spend a little time making sure that we all have some background on why it's so important to support people with serious illness and end-of-life care, and especially addressing disparities for this important population. So I realize that everybody most likely knows what it means to be nearing the end of life, but perhaps not everybody knows exactly what we mean by serious illness. So what is a serious illness? So the academic definition of serious illness is a condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregiver. And to make this a little bit more concrete, some examples of serious illness include later stage cancer, congestive heart failure, kidney failure, and dementia. And while anybody of any age can have a serious illness, it's important to know that the majority of them are older adults. I also just want to pause here and mention that I think we all know there's a tremendous amount of money that's being invested, or at least was being invested for people with serious illness and interventions for people with serious illness. And we are all so, as funders, incredibly grateful for that. But that's not necessarily what we are focusing on. So we as funders are really focusing on kind of those wraparound services that help improve the experience of people with serious illness, such as palliative care is one example of that. And the reason why this is so important is that as people have serious illness, there is a tremendous amount of unnecessary suffering. And that includes having a necessary amount of pain and discomfort, caregiver strain and burden, socialization, even unwanted or unnecessary treatments. And it's not just people with serious illness that experience so much unnecessary suffering. It's also people who are nearing the end of life. And I just want to pause and recognize that clearly dying is a difficult experience. But what we're really focusing on is the unnecessary suffering on top of that people experience. And so we have data from bereaved family caregivers that tell us that their loved ones, 1 out of every 4 person at unmet needs for pain management or help with breathing, 2 out of every 4 had unmet needs for anxiety or sadness, and 1 out of every 4 family member wasn't even kept informed about what was happening. And just to give you a little bit more of a flavor of what this means for an individual. This is a story about, this was as told by a bereaved family member about an older adult with dementia living in an assisted living facility. And what they told us is that the med techs controlled the morphine in their pharmacy dispensary. So we couldn't ever take control of that. But somebody having to be on duty, it was the middle of the night, my mother needed morphine, and they disagreed. They said, "You're killing your mother, you're taking your mother's life." And we had to wait until somebody came on duty to override that decision. She had shortness of breath, she had fear and anxiety, she had pain, and the quality of my mother's death was greatly diminished. I think she suffered. I think she struggled. I know she struggled. And so this is just one of many, many, many stories we hear. And something else important about this story is that what you can hear in there is it wasn't just the experience of her mother, but it's the impact that it has on everybody around her, the impact it had on her. And this does impact, beyond this story, providers, family members, friends. So I want to emphasize that as you hear, there's a tremendous unnecessary suffering for everybody when it comes to serious illness end-of-life care, but there's even more of an issue for people of color, of certain income, certain gender, certain geographies. And so I just want to highlight for a moment some of the significant racial disparities that are experienced by people with serious illness and nearing the end of life. What we know is that compared to white Americans, people of color have significantly less pain management. They have care that less frequently matches their preferences. They experience more judgment from medical providers, and they have lower utilization of hospice, which we know is designed specifically to alleviate suffering at the end of life. We are aware of barriers that exist, things like provider-related barriers like implicit and explicit bias, individual community-related barriers such as distrust of the medical system, and systems-related barriers such as inadequate payment structures or geography. So these barriers exist, but what we really want to focus on is the fact that there are interventions that have been designed that are being identified or being scaled. And the role of philanthropy has this really important role in driving meaningful change. So with that in mind, I want to turn it to our featured panel speakers who are funders. So I am so excited to have Dan Tuttle here, who's the Director of Health from the Stupski Foundation, Julie Boudreau, who's the Executive Director of the John and Wauna Harman Foundation, and Rachel Watman, who's the Vice President of the Rita, Alex, and Hillman Foundation. So thank you all so much for joining. And I want to start by asking all of you, it's actually a two-part question. So we'd love to hear from all of you why your foundation decided to prioritize focusing on disparities in serious illness care, and specifically what kind of interventions you're currently funding. And Dan, if that's okay, I'll ask you first.
Sure, of course. Thanks for the introduction, and to all of you for being here. You saw the stats. You saw the stats. That in and of itself is enough of a reason to focus on this. And you can see from that American healthcare was designed to serve native English speakers who are commercially insured. And American healthcare focuses on acute clinical response rather than on any upstream sources of well-being for individuals or communities that are ultimately what determine people's health status. And we decided to focus on this even more now because given the rhetoric and the actions of the current federal administration to punish equity language and defund Medicaid, people who are in powerful and privileged positions, such as those of us who get the chance to be in philanthropy, are responsible for showing their values and their commitment to equity, racial equity, and other forms. So in terms of what we do at the Stupski Foundation, we're a private family spend-down foundation based in San Francisco, and we give in 2 geographic areas. One is the state of Hawaii, and the other is 2 counties in the San Francisco Bay Area. In Hawaii, our focus is geographic. Oahu, which is where Honolulu sits, is where most of the power is for the government and economically. And the neighbor islands, which is the term for everybody else, they get overlooked. So there we focus on strengthening healthcare infrastructure and support for social determinants of health, all with a focus on neighbor islands. They haven't had the same chance to be at the table. In the Bay Area, and you'll hear much more about this later, we focus on closing racial equity gaps in serious illness care, specifically for Black African American, Chinese, and Latino populations. I'll mention 2 of our approaches. One was traditional, which was find and fund community-based organizations providing racially concordant longitudinal care outside of the walls of a clinic. You'll hear more about that from our wonderful guest, Anni Chung, later. And then the second way we approached it was less traditional, and that came with a focus on shifting and sharing power, in that we set aside a pool of money that local organizations could decide how to allocate to build awareness and acceptance of serious illness care services in ways that are linguistically, culturally, concordant. Anni, who you'll hear from, also happened to chair one of these participatory groups in San Francisco focused on monolingual Chinese seniors.
Thank you so much, Dan. And Julie, I would love for you to answer that question next. So what made your foundation decide to focus on addressing disparities in serious illness care and end-of-life care? And can you give some examples of some of the things that you're funding?
Definitely. Thank you. And thank you, Lauren, for setting the stage so well for us with those slides. It does, as Dan said, it really kind of tells the story for us. But I know every foundation is different. And I'll just give a few bits of our history. We, for decades, had been focused on helping support programs that help Americans have conversations about what matters most to them so that they're better prepared to, and they and their loved ones are better prepared to navigate serious illness and end of life through sharing and talking amongst themselves, which is known to help improve the chances of someone's preferences and wishes being honored when they enter into a more difficult phase of illness, and especially when they approach end of life. When we sort of opened our eyes to the fact that entire populations in the country were left outside of these efforts, these education efforts, which I myself have been part of for decades, and also many of the other members of our leadership as a foundation have done this kind of work for a good portion of their careers. And several years ago, we looked around and saw, well, wait a second, we're just missing entire demographics because we're using a model that was coming from a traditionally, European background centered cultural lens and approach around where people get information, who people trust to receive information from, and so on. So we decided that was just basically unacceptable. And when you look at the impacts and the harms that come about because people are unprepared, and you figure that those are compounded for communities of color and other disenfranchised communities, it's pretty motivating. And then we just started the process of educating ourselves. And I will say that the deepest gratitude goes to our grantees because our programmatic approach shifted to funding groups that serve communities of color, and particularly we needed to because we're a very small family foundation with limited resources. And we decided that because we had a strong network in the community of professionals serving Black Americans across the country around these kinds of conversations and advanced care planning, that was where we would really focus. And so now we primarily fund initiatives that are led by and partners by Black Americans, and that work with community organizations that partner specifically with community leaders, and examples are, faith communities is a strong example, but also now broadening out to other kinds of community organizations and community providers who aren't necessarily part of the traditional picture of what care looks like. And I'll say more about that later when we get closer to introducing our program leaders. Thank you.
Much, Julie. Yeah, Rachel, we'd love to hear from you as well.
Thanks, Lauren. Thanks, Lauren and Emily and GIA for bringing us all together and the opportunity to share. Thanks to our guests and to the participants on the Zoom today. Just to provide a little bit of context, I'm at the Rita and Alex Hillman Foundation. We are a national funder. We're located in New York City, and we're really committed to improving the health and the healthcare of all people, but especially groups and communities who experience inequity, discrimination, and oppression. And we define this population very broadly to include the economically disadvantaged, BIPOC, LGBTQ people, rural populations, people experiencing homelessness. Basically, we are focused on efforts that support programs to reduce barriers to quality health care, because we at the Hillman Foundation believe that by improving care to populations that experience inequity, we can improve care for all. And we do this by supporting programs which comprise 3 key criteria. We're focused on efforts that are nursing driven, that is, that they're rooted in nursing's holistic and their integrated approach to care. We're focused on programs that are innovative, that are bold and creative. And then again, we're focused specifically on elevating the health of marginalized populations. We don't focus specifically, exclusively on just end of life and serious illness. We have programs that are focused on maternal child, young adults. We span the lifespan. But our serious illness and end of life programs are very important to us. And we began focusing on marginalized communities about 10 years ago. And this came about in response to needs that we were hearing directly from nurses in the field, and what we saw as a real gap in philanthropy. And what we did was we decided to create a pipeline of programs to support our grantees' work. After talking with them extensively, we learned that programs are in different places when you give them funding. So we created 3 grant awards. Our first award is focused on emergent innovation ideas. These are bold and untested pre-evidence programs. Lisa's going to be talking to you a bit about that from the Humane Prison Hospice Project. We also focus on programs that are evidence-based, that are ready to scale. And at the far end of our grant-making continuum, we have a dissemination award for programs that are really primed for national replication.
Thank you so much, Rachel. And I just want to say that I've had the pleasure of working with all 3 of you over the years, and I've always been so impressed by your partnership and how you've shared information, and I think how you've all benefited from each other's programs as well. So just want to mention that. I'd love to hear a little bit more about, when we talk about reducing disparities, we often talk about not just sort of what we decide to fund, but also how we go about funding. And I'd love for each one of you to share a little bit more about kind of how you might fund that might be a little bit different to how traditional philanthropy or how perhaps you had funded in the past. And maybe I'll, again, start with you, Dan, if you don't mind sharing.
Sure. Wish I had more time to expand on all of the ways we do it, but I'll boil it down to a couple. So first, remember that we're geographically focused at the Stupski Foundation. So therefore, how we go about doing this is a little bit different because we as a program team on the foundation can shoulder the responsibility of getting to know the organizations that are operating in our communities. This leads to a couple different things. One is a reduction in the need for open calls over time because we have a better sense of what's going on and don't need to have organizations go through an RFP process. We have done an RFP process, it's not entirely out, but there's a need for fewer if you can focus. A second advantage that comes is that we can build more and more trust with understanding what organizations are doing, because there's a lot of continuity, multiple years worth of relationships there. So we can ultimately reduce kind of the paperwork and reporting burden because we have a sense of what's actually happening. I also want to recommend funding flexibly. We had the privilege of being able to shift from a board-driven, board approves every single grant process into an annual program budget process. And this shift of trust, or the shifting and the sharing of power from the board down to the program staff, allow us to show up in conversations actually with the version of a checkbook in hand. We don't have to force partners that we talk to in the community to prove to our board the case for investing in any kind of equity, or forcing them to repeat that case over and over and over again. Instead, board trusts that we're going to get the work done. They're willing to check on it, and we can transfer that trust on to community-based organizations. The last thing that I'll mention is that we've had multiple participatory grant-making groups where the whole goal is set aside a specific pot of money and trust people who are closest to the challenges in languages I don't speak, to be able to figure out what is best for addressing and serving the needs of the people in their community. You'll hear plenty more from that from Anni later.
Thanks, Dan. And love to maybe hear from you next, Julie.
Sure. And I know we really want to get to the program leaders, so I'll keep it super brief and answer questions later. So it comes down, it's so many of the things Dan said, but for us on a smaller scale, it comes down to relationships and time, getting to know people and establishing trust on both sides. And this for us has been so crucial because we did not know what was needed. We needed to learn. And the teachers, again, were our grantee partners. And they weren't always grantee partners at the beginning. They were people in the network who we wanted to get to know because we saw they were doing close-in work, that the affected communities have the greatest understanding of what the needs are, and also how the approaches need to be shifted. And so I'll just take this as a moment to kind of tee up PAUSE and its amazing leader, Alica, who you'll hear from shortly, that Alica, I'm not even sure I've had a chance to tell you what an amazing educator you've been, and the hours of time we've shared, with just such a generous exchange of information, so that I got to learn how I needed, and we as an organization needed to shift our thinking. Who are the real stakeholders here? Who belongs at the table? And how can we support that process at the grassroots level? And you'll hear more in a bit. Yeah.
And I know we're all eager to hear from the program leaders, but Rachel, I do want to give you an opportunity to answer this question as well.
Thank you, Lauren. I'll be brief. I think one of the themes that you're hearing here from Dan and Julie is one of relationships and trust and mutual learning, working with grantees, with thought leaders in the field as partners. So we have used the RFP process at the Hillman Foundation just so we can solicit ideas directly from the field, so we get to know what's happening in real time and get to meet the people doing the hard work and make introductions, whether we find people or not, make introductions around shared interest. I want to give you one specific example of how our grant making differs from other funders in our efforts to support marginalized populations. So back in 2018, after listening to people in the field, we heard that there weren't many grants that were focused on pre-evidence programs. We wanted to support bold ideas that needed funding to jumpstart their programs. a vicious catch-22 in funding is that we all demand that programs have a robust evidence base, and yet it costs money to collect data. And it also needs a lot of time and resources to do that. So we decided to create this serious illness and emergent innovation program to provide funds to support programs to collect that evidence base so they can create a model of care. And one of the reasons our program has been successful beyond those terrific people we support is a partnership that we've had with the Arthur Vining Davis Foundations for the past 5 years, which allows us to double the number of grants we make each year. And shout out to grant makers in aging and the funders community. We met the team at Arthur Vining Davis Foundations because of a convening that you all hosted. So thank you. I'm going to turn it over to you, Lauren, for maybe one more question, and then we'll get to the stars of the show.
So I have one more question I'm dying to ask you, but I'm going to hold it. And if we have time at the very end, I will ask you of that, because I think we're all really excited to meet the program leaders. And the important message is that there are solutions that exist. And so we just want to highlight 3 of these solutions for all of you today. And so what I'd love to do is ask Dan, Julie, and Rachel to introduce the program leaders and maybe share a little bit more about why you selected them to speak at the webinar. And Rachel, I'm going to start with you this time.
Great, thanks, Lauren. So I'd like to introduce Lisa Deal. Lisa is the Executive Director of the Humane Prison Hospice Project. And here she leads the organization's mission to revolutionize end-of-life care in prisons. We focused on this program, and it was really easy to decide to fund this program because there were a number of compelling reasons. They are one of our 2023 Serious Illness Emergent Innovation Awardees. Again, this is the program that I mentioned to jumpstart bold ideas. And the reason we selected them was because of the compelling need for this program. This is a marginalized population. Not only is it a marginalized population, it's a marginalized population within marginalized populations. Not many philanthropic efforts go to supporting incarcerated people. Another reason we chose to fund them is the opportunity to work with other partners to expand their model within the California Department of Corrections and Rehabilitation. And because Lisa and Laura and the team at the Humane Project are just terrific people doing amazing things with skilled resources and talent. So I'm going to turn it over to Lisa to tell us more about the Humane Prison Hospice Project.
Lauren, would you like me to do that now or wait till the introductions are done?
Oh, thanks, Lisa. That's a great question. I think I actually, let's go ahead and wait for a minute and let me over. So Dan, I'll turn it over to you to introduce Anni. Thanks, Lisa.
Anni Chung has been the CEO of Self-Help for the Elderly, based in San Francisco since 1981, provides care for more than 40,000 seniors in San Francisco and across the Bay Area. And the most important thing to know is if you want to understand what's actually going on in San Francisco, you just need a 17-minute conversation over tea with Anni. And she has my absolute deepest loyalties. And it's a joy that she's on the call today.
Thanks, Dan. And Julie, I'll turn it over to you to introduce Alica.
My pleasure. So Alica Forneret is the founder and director of PAUSE. And PAUSE is a relatively young organization, very innovative, very creative, very dedicated. And their purpose is to support people of color through grief and end of life. And they do that by creating and supporting culturally sensitive, safe, expert-informed resources and experiences for community members. And we as a foundation, we're really drawn to their work because the model that they employ is exactly the kind of process that helps move programmatic focus out of the traditional mainstream kind of known institutional worlds that a lot of us travel in and move to where people really live and what that looks like, and how our definition of who belongs can be expanded in a really effective and creative way. And so it's really been a pleasure, and you'll hear more momentarily from Elisa.
Super, thank you. I've had the great privilege of both working for a foundation and also running an organization, so being kind of on the funder side. And so I was just thinking, you know, if any of you program leaders have wondered what your funders were saying about you, you now know. So, with that, we would love to turn it over to you. And we'd love to hear a little bit more about kind of your approach to addressing disparities. And if you don't mind sharing a little bit about kind of how you decided to focus in that area, and maybe just share some of the kind of outcomes that you're starting to see. So that's the first three different questions in one question. But I think, Lisa, seeing that you were about to begin, I'm going to turn it over to you to start.
That's fine. Thank you, Lauren. So as Rachel said, we really work to revolutionize the end-of-life experience in prisons by doing advocacy work, but largely we train peers to be caregivers in the prisons, working alongside the multidisciplinary team. And our organization is really rooted in working around this improving end-of-life care in prisons. And this peer support element is really a focus that we decided to have for various reasons. So our approach at a high level is all about addressing disparities, and people living in prisons, as Rachel said, are one of the most marginalized people within our whole country. And they are really, I liked how you described it, a marginalized population within a marginalized population. And within that prison population, our work really focuses on both the aging and the dying, who are further marginalized in prisons that aren't set up to care for them, which I'll talk about in a bit, and also on training and supporting and empowering peers to care for them. Our approach is peer-driven. We feel very strongly that peers within prisons and for those who are aging are really respected in a way that many of the correctional staff are not, because a lot of biases that have happened and just the care that happens in prisons. Our approach is very community-centered. Prisons are very unique communities, and we really try to address and meet the needs of those communities. And we really are going into prisons learners. As we facilitate these programs, we tell our participants that we are not here to teach you, we are here to learn with you, because we have a lot of experience in our staff and our team in end-of-life care and delivering end-of-life care, but we do not know what it is like to live day to day within the confines and the realities of a prison system. And then our approach is also very system responsive. Correction systems are very complicated, are not often well led and well run for various reasons. They're often have incentives that do not align with providing good care. So we really try to learn and work within the systems and work with the peers, with the correctional staff in the prisons, and then also with the prison systems. And then, focusing on the peer caregivers. So peer caregivers really bring this level of trust and shared experience to their work, which traditional corrections lacks. And we, as I'll talk about when we get to the outcomes, really have seen the power of that work and the trust that can come from that. Another focus of our approach is that prisons are not built for the aging and the dying. So prison systems and the physical layout of the prison is not set up for the aging. So our work really tries to fill this gaps in care by focusing on the peer caregivers who are caring for folks. And then finally, our approach really humanizes caregiving. In a system that often strips people of their dignity and their humanity, we try to bring some of that back. So Lauren, I'm going to ask you another question. Do you want me to talk about outcomes now, or do you want to go through okay. So in terms of outcomes, we are observing very slowly, I have to say, but really seeing cultural shifts within the dynamics within the prison between caregivers and the correctional staff. The caregivers that we train work alongside the correctional staff. The correctional staff witness these acts of compassion and care that oftentimes they're a little shocked by, because they're not the typical, sense of what happens within the prison. On a very concrete level, our training boasts a near 100% completion rate. And I say that because it's important. We have more peers who apply to be trained than we can accommodate in our programs. And we take these folks through a very intensive, oftentimes a 2-week, 8-hour a day, 80 hours in total training that delves deep in we teach them, practical ways of providing caregiving, but they also look deep within themselves. We do a lot around culturally competent care, trauma-informed care, which brings up trauma they've had in their own lives. So the fact that all our participants stick with this and, stay with us for those 2 weeks is pretty compelling. Our participants, the peers that we train, report feeling valued. They report feeling a part of a community that they didn't have before. And they report increases in their confidence. Some of them have been doing informal caregiving for a very long time, particularly in the women's prisons. They've created these communities of care, and we give them language and skills to really name that, which is really, really meaningful for them. They also note that it brings them hope. It brings self-worth and purpose to their role in the prison. And a lot of times folks describe doing this work as a way of atonement or giving back, kind of righting the wrongs that maybe they have done in their own lives. And it's very powerful for them. And then we hope over time, we can't really provide evidence of this yet, but we hope that these outcomes may really serve as shifts for later policy changes around compassionate care, around compassionate release, and just around envisioning prisons in a new way within California and some of the work that we're starting to do nationally. So I'll stop there.
Thank you so much, Lisa. So I'd love to maybe turn it over to Elisa, if you don't mind going next. So again, we just love to hear a little bit more about your approach, as well as kind of how you decided to arrive at this focus, and then any kind of initial outcomes that you're seeing from your work.
Of course. Thank you. Thank you, Lauren. And thank you everyone here today. Again, I'm Alica Forneret. I'm the founder and executive director of PAUSE, and how I arrived here was through personal experience, both my own experience navigating the healthcare system as a Black woman in America, navigating the death of my mom, Deborah, almost 10 years ago, and also as an entrepreneur in the death and grief space. So I came to this work, after my mom died. I recognized that first, my experience as a Black woman feeling anger in relation to my grief and to that death and how it was handled was met very differently than other folks and their relationship to grief and anger. As a Black woman being angry about something, like I said, it's just met very differently. So that sort of pushed me into this understanding the differences in how folks experience, just this world of grief. The next was within the healthcare system. As an example, I tried talking to my 7 OBGYNs, 5 of whom were white, about how as a Black pregnant person in America, I spent the entirety of my pregnancy worrying that I was going to die every single day. And I was often met with the sort of, you'll be fine, push it off. We know the numbers, but it won't be you. But then when my Black doula that was funded by the state of California, who has experience with death and dying and end of life and, Black maternal mortality, met me in those conversations, she validated me in a way that nobody else could. And particularly folks who were coming from within institutions and healthcare institutions that, I was told would take care of me. And then lastly, as an entrepreneur. So I stepped into this work, and really for me in founding PAUSE and collecting and like working with the folks that are working with us now at PAUSE, it became very, very clear that there was an invalidation of our work. There was a lack of support, both financially and just in the business community around our work. There was a lack of validation from the systems and our work. And also there was really just this gap in what kind of care needed to be felt by folks working in the end of life community and in the grief space as folks of color, and particularly for the folks that we support in our programs, women of color, non-binary folks of color, and queer folks of color. So our approach to this and our theory of change really from the get with PAUSE has been, we all see the stats, like Dan said. I think there's no denying, there's no looking away, there's no question. But for us, our theory of change was really rooted in how do we approach this and how do we respond to this in a way that is collaborative and community-based and innovative and new and positive. Because I think what a lot of the folks, both on our team and myself included, and from the communities of entrepreneurs that we were working with is, we know this is the reality. Where do we find the light? Where do we find the network? Where do we find the hope and the forward movement? So we do this in a couple of different ways. We primarily started the focus of our work on working with the providers who are already out there doing it. And like Julie said, our model has really expanded and redefined, like who were the experts, who should be in the room, who is worth inviting into something that can be labeled, huge air quotes, as an accelerator or a business development program with leaders in it, because the folks that we invite into our program and that we share that space with have been not accepted, not validated, and often don't fit in these traditional places that are trying to support them in the work, let alone the fact that they're folks of color, they're working in our space, which is taboo and not something that someone in traditional business development focused spaces want to talk about anyway. It's death, it's grief. So we support the folks that are already doing the work in community. And then a huge thing that I know Harman was really interested on top of just this like redefinition of who is valuable to have in the room when we're dealing with death and grief is also embedding in all of our programs and just the way that we show up this amplification and network building across both the early stage entrepreneurs that we work with and the community-based folks that we work with and larger systems and institutions. And then from there, what's on the horizon for us is we're moving into doing that systems level work after knowing that where we've put our focus and energy and time and resources and money is with the folks who are, like everyone has said today, living and working this like I was every single day as both their personal and professional life. Outcomes, I'm not watching the time. I'm sorry. I'm usually really good at multitasking. Am I okay to talk?
You're good. Yes, please.
Okay,
yes.
Great. Thank you. In terms of outcomes, one of the big things for us is really just I keep saying this, but it really has felt like an uphill battle at times, like redefining the value of this work. And one of the things that we're seeing is there are a lot of folks and providers, particularly at, different levels. If we think about these systems hierarchically compared to the folks who are doing this community-based work, who are hungry for these resources, they just want to be connected to them. I sit in so many rooms and so many conferences where folks say, if I knew that I could get a Black queer doula, a death doula for my patient, of course I would introduce them to that person. But Elisa, can you maybe find them for me? And that to me is like, I'm comfortable with that at this point, but really for us, this next stage is to think about how we can embed those folks more within the systems versus just making referrals. And at the end of the day too, one of the biggest, and we talk about this, Julie and I have talked about this a lot, and I talk about this with our other funders, is when we think about the value of data that we're collecting. Yes, I love, quantitative. And at the same time, we walk away from our events and we walk away from our program with folks telling us things like, this is a quote from one of our recent alumni, I learned that I am more capable than I think, and that we need people around us to see our light and help shine it back to us. That to me has touched my heart in a way to know that, you know, this incredible young woman who is a mother and a death doula and who is a person of color said, all I needed was to be in the room with people that can make me feel like the work I'm doing is important. And that to me is such a low bar. I'm like, we can do that every single day. Why aren't we? And when I think about how Jasmine, you know, walks away from these programs and these interactions and things that Harman funds, like our BIPOC pop up at Endwell, which is the end of life conference every year, where we now get to show up and bring folks like Jasmine into the room. My, you know, the biggest question for me is like, and that I'm very excited to answer working at PAUSE is, if that's how she feels from one interaction of folks validating the work that she brings to the table, how much healthier and better would our systems and our community be if all of our providers of color could feel that? And that's really the end goal for me. And some of the short-term outcomes that we're seeing now is the, I think, grounding and affirmation of the folks that are working in community. And this next step for us is really, now how do we start making connections to them with larger opportunities and institutions?
Thank you so much, Lisa. So Annie, I'd love to turn it over to you. Again, if you could share a little bit more about what you're currently doing, what made you decide to focus in this area, and some of the outcomes you're seeing.
Hi, everyone. First, I want to thank Lauren for introducing us to the Stupski Foundation and ask us to try submit a grant. And I really want to thank both Dan and LaRue, who's on this call at this meeting, really for trusting in us that we could, with your resources and support, really try to close this gap, right, that is happening in the Chinese community in San Francisco in particular. So when we got the grant from Dan and LaRue about 3 years ago, we're ending the 3-year cycle at the end of March. Just to show you how difficult this talking about end of life and having our monolingual seniors to talk about and actually go through the process of understanding and then finally hope that they will complete the advance directive is such a difficult task that when we submitted our proposal to Dan and to the Stupski, to Dan and LaRue, we were only offering to reach 500 people for the year one, maybe 750 elderly for year two, and maybe 1,000 for year three. And even those low numbers, we didn't think that we could achieve it because no senior will come to our workshop when we talk about end of life and how you plan for your dying. That's just the reality. But lo and behold, when we set out, you know, to really try very, very hard, I will share with you the outcome and the output later. But how we approach this is to first kind of like cast the net. We have to, there's a roughly, by background, 200,000 residents in San Francisco that are Chinese, and 36%, about 320,000 are Asian Pacific Islanders. So it's a very, very large population. And how do you reach them? We do serve over 40,000 seniors a year, but talking about this subject matter is not the usual come fill out your form for affordable housing or help you, you know, get food support and nutrition program. So we have to make sure that we get a feel working with our partners, which is the AAMG, the All American Medical Group, a very large Asian serving physician association, also with St. Francis Memorial Hospital and St. Mary's Medical Center. We feel that traditionally, as a healthcare and social service entity, we're not quite tied in when the patients become inpatients. Once they discharge from the hospital, then we almost sometimes get the case by accident if the seniors or their family come to us. So we must again, the approach is to get a feeling of do people fill out the directive when they enter into the medical center? Very, very, very few. So we said that through social and ethnic media, let's try to cast the net as wide as possible. And we offer a lot of incentives for people to come back to respond to us and then say, I'm interested, or I'm ready for a conversation, or help me fill out the form. So with that out of the way, then we do intensive workshops among senior housing settings and senior center settings. We go in, whether it's 20 people that signed up, and then gradually, the whole senior nutrition program, sometimes over 100 elderly, would sit there after lunch or before lunch and listen to Yu Ling, our director of social services, to give the whole spiel on why it is important to do advanced care planning. And gradually, then the last step is to put in the last stop, which is actual social workers to help them fill out the form. We use Dr. Sidori's form, the prepared form, which is already translated, very, very detailed, help the patient and the family step by step go through the whole planning process. And the AAMG doctors helped us produce 20 videos to demystify what it is, that there are some invasive procedures that if they don't know, then they usually skip that part that say, I don't want CPR, I don't want force feeding, I don't want to be intubated. All this we explain, and the doctors help us explain in some bilingual or Chinese video. And then the last part is to really focus with our two hospitals that when they discharge, as well as the AAMG discharge patients to us, then we do some intensive case management, care coordination, go through the ACP process, help them find other supportive services that just, hold that part of their life, better quality of life. Lauren, you mentioned earlier that 40% of the Asians said that at the end of life, they don't get much respect or attention at all. And it is true. Our population is very large, but yet there's a lot of deficiency in the healthcare because of language and cultural barrier. So now I shift back a little bit to what Dan said. As a funder, they want to close the racial and the ethnic gap in advanced care and end-of-life planning. So with our grant, we're able to very quickly remember the low number that we proposed. Stupski and Stupski Foundation accepted our low goals. But at the end of these 3 years, we have captured a total of almost 53,000 people that attended our virtual and physical in-person workshops. We have completed a total of 390 forms, which by a lot of the professionals that is unheard of, when we begin the project. And then we did 88 workshops, and over 80,000 Chinese view the videos that our doctors made. And with a very serious illness, total of 222 patients were referred to us for care coordination and intensive management, and also completing the advanced directive. So we felt that it's a very, very quite a successful project. Now, Dan mentioned that on the other side, for 2 years, I co-chaired the re-granting project, which Stupski gave us about 200,000 to re-grant to the community partners. We actually produced an ebook that I could provide a link to those of you that are interested. We picked 7 projects, all by community partners within the Chinese monolingual community. And these projects reached over about 140,000 people through ethnic media, social media, direct contact. We have the Deaf Over Dim Sum, and we have the, the ambassadors that are seniors themselves going back out to talk to the seniors about ACP. And then we have, the dual role interpreters that are trained by Gail Tang at City College, so that they are more bilingual, bicultural interpreters that could help us in the ACP work. So by far, with the two approach that Dan provided us resources and the trust that, really they gave us and the flexibility they gave us, we felt that we've really come quite far in this field. So I want to end by saying that when we go out to the seniors to talk about end of life planning, we really stress the fact that advanced care planning is not about giving up hope. We're not hospice per se. So you have to explain, how palliative care is different from hospice care, home health care, but it is not giving up hope. But it is really about ensuring that our seniors are heard and our voices are heard. And it's about living and dying with dignity, really in true accordance with our deepest value and wishes. So that's really the mission and goal that we uphold for the past 4 years when we approach this, and hope that we will able to continue a little bit more work and find some sustainable ways to sustain the project after the funding is gone. But again, thanks very much, Dan, and thanks very much, LaRue and Lauren, for the opportunity for the Chinese community to do this work. So thank you.
Thank you, Annie, and thank you all of you for your incredible work. We sadly only have 3 more minutes. And I think I had 2 more questions. So Emily, we needed this to be longer. But I think maybe before we close, I might just ask, turning back to the funders, if you could just briefly maybe close with something you'd want to share about how you think foundations can be most effective in supporting our communities right now. So Dan, sounds like you want to say something.
One of my favorite parts of this hour was hearing Alica's, I will call it a plea, she did not, to the funder community to accept experiences and accept qualitative accounts and stories as outcomes. The outcomes conversation is too reduced to numbers. So I'd encourage anybody on the call to not fall into that trap.
Thank you. Is there anyone else who would want to share a comment? Julie looked like.
Well, it just, that really resonates. And also as research institutions get their funding reduced potentially quite dramatically, these kinds of community efforts to gather information with a more ethnographic type focus will become increasingly important and valuable. We're all doing work to touch people's lives in ways that ultimately we want to have change how they feel inside, and them and those who love them. So I just underscore that.
Thank you. Yeah.
And Lauren, I'll just add, I think now is a time for funders just to stop and listen. I think it's really important that we ask our thought partners, our grantees, what they need right now, given the changing circumstances. We surveyed our grantees and found like the top helpful resource beyond funding right now was community and network building. And as a result, we're going to be doing some of those efforts at the Hillman Foundations with others. But I think it's really important to ask how we can be of best service with the people that are doing the heavy lifting.
Wonderful. Thank you. Thank you. And I'm also just so impressed. I mean, the other thing I'm hearing is that, you and other funders in this community have been funding in the area of addressing racial disparities for a very long time. And regardless of what's happening in the political climate, I know you are also continuing and planning to continue to fund in this area for a really long time. So just also just want to acknowledge that, the importance of that. But all right, we're at time, but Emily, do you want to just quickly close? All right, sorry everybody for being a minute over.
No, not at all. So thank you all. This was really great. I'm so appreciative to the funders on the line for your work, to Lisa, and Annie for your great work and sharing that with our network. And to our guests today for funders on the line from within the GIA membership. Thank you for listening and taking the time to hear what great work is happening in this space. We would love to continue the conversation through our serious illness funders community. So if you're not involved in that and want to be, please reach out. There's just such great work happening, such great conversations. These are, as you can tell, very smart and thoughtful people. And so we'd love to have you part of this group. We meet next in May and would love to have you involved. There's a white space in funding for this. So there's lots of opportunities we can share with you. So thank you all. We will end the webinar now, but just so appreciative of the work that you do. Thank you.